UEG Talks, Gastroenterology to Go. Welcome to our GI podcast. Listen for fresh insights and perspectives in science, education, and professional development.
Hello, everyone. Welcome to this slightly different episode of the UEG Talks, calling it an add-on or a special or a plug-in episode to our previous podcast recently recorded or released on prevention of esophageal cancer with Professor Massimiliano Di Pietro. In that episode, we discussed various aspects of epidemiology of esophageal cancer, definition of Barrett's, and role of surveillance and prevention of esophageal cancers. If the listeners haven't listened to that episode, I would strongly suggest that they listen to that episode first before listening to this short add-on. We're trying to make it as short as possible for this. In that episode, Professor Di Pietro nicely summarizes various aspects of prevention of esophageal cancer, mainly from the Barrett's point of view. He also gives some great tips on recognition of Barrett's, definition of Barrett's, role of PPI in Barrett's, and we also discuss about screening, surveillance, amongst other things. And it's such a brilliant episode, and Mass is full of knowledge and advice in that. So I really strongly suggest listeners listen to those episodes first before coming to this. And the reason for this plug-in episode is since we released, some new evidences have been published. And I feel it's probably, and a very important, or probably a significant publication in this field and deserves this special discussion. So whether it's game-changing or practice-changing, we need to see. So I have re-invited Professor Massimiliano Di Pietro for this discussion. As per my previous introduction, he's a professor of gastroenterology at Cambridge University Hospitals in the UK. He's the lead for British Society Barrett's guidelines and is also one of the authors of the European Society of GI Endoscopies Barrett's guidelines. Massi, welcome back again.
Thanks, Pradeep. It's really exciting to be here again. I'm kind of getting used to it and I'm really enjoying it.
Thank you so much. So, Massi, I think we briefly touched upon surveillance there. I think the one thing you mentioned in that episode is contentious. So, this new study that's been just recently published, BOSS study, can you briefly explain about it? What was the design of the trial?
Yes, this was the first randomized trial in the history of Barrett's esophagus, which addressed the impact of surveillance on the outcome of patients with Barrett's esophagus. And it began in 2009, so it's quite a historical trial, which has been running for the past 12, 13 years in the UK. And the trial was a randomized controlled trial where patients with Barrett's esophagus with at least 1 centimeter circumferential or 2 centimeter, if non-circumferential, were randomized to have either 2 yearly surveillance or what they called at-need endoscopy. 2 yearly surveillance, we appreciate now, is quite a frequent surveillance compared to what is currently recommended by the guidelines with up to 5 years for short segment of Barrett's. Whereas the definition of at-need endoscopy is slightly cloudy, and essentially patients were cancelled about being randomized to that arm of the trial and were offered an endoscopy if they developed symptoms, unusual symptoms or new symptoms during the course of the trial. And the trial ran in an extraordinary number of hospitals in the UK. So 109 centres in the UK recruited to this trial with a minimum follow-up of 10 years.
Right. This started 2009, so most of the patients were recruited by 2011. What was the sort of roughly the median follow-up, Massi, on all this when the results were reported?
Yes, the median follow-up was 12.8 years.
Right, so that's quite long. And you mentioned randomized. Was it at an individual level, wasn't it? A patient level randomization rather than, center-wise?
Yes, it was not a cluster randomized, it was at an individual patient level, yes.
Lovely. Okay. Of course, the procedures were done a long while ago. I guess things have changed how we do things now. When I say a long while ago, even 5 years in the field of Barrett's is a bit old, I think, in this day and age of AI, endoscopic technology and all that. So can you comment on how the procedures were done, whether they were done any differently than, let's say, our European colleagues or how we do currently?
Yes, there wasn't actually, as far as I understand, I have to disclose, Cambridge was not part of this trial. But as far as I understand, there wasn't any specific recommendation in terms of performing procedures in a specific way. So obviously, it was advised to adhere to the guidelines recommendations, but we don't actually have in the trial some data to judge the quality of the endoscopy, such as adherence to Seattle protocol biopsies or number of targeted biopsies. So we don't have this kind of information to judge the quality. But yes, I mean, certainly being a historical trial, you can assume that the technology has evolved during the course of the trial. And the guidelines have also changed because, for example, in the UK, there was a major change in 2013 where the intervals were revised, but the trial maintained the original interval recommendation in terms of frequency of procedure in the surveillance arm.
But is it fair to say that standard white light endoscopy were done along with Seattle protocol biopsies? That's a fair comment on the procedures that were done in that era. Is that right?
Yes, I agree.
Okay. And what were the outcome measures? Can you summarize the outcome measures that were chosen as part of the trial?
Yes, the primary outcome of the trial was overall survival in an intention to treat analysis. The trial also had a number of secondary outcomes: cancer-specific survival, time to diagnosis of esophageal adenocarcinoma, stage of cancer at diagnosis. The authors also looked at the frequency of endoscopy and any adverse event. Perhaps on the primary outcome, we have to maybe chat a little bit about the meaning of overall survival, because we know that the Barrett's patient population tends to be an elderly population, and often Barrett is associated with other risk factors for death, like, for example, cardiovascular disease, metabolic syndrome. So one could question, is that the right primary outcome for this trial, where you would expect a number of patients with Barrett's esophagus to die anyway of other causes of death? And we know from previous research that, in fact, the commonest cause of death in people with Barrett's esophagus is not esophageal cancer, but is generally cardiovascular disease. So obviously, from a public health perspective, you want an intervention to benefit overall survival. But one could argue whether this particular primary outcome was correct and was going to lead significant results anyway.
Okay. But they have, in the secondary outcomes, I guess what we are interested in is esophageal cancer-related mortality and, I guess, stage of cancer, maybe, that's more important.
Yeah, so they had cancer-specific survival, so death by any cancer, but they had time to development of esophageal adenocarcinoma.
Lovely. And Massi, what sort of numbers were they able, if you remember, were they able to recruit into each arm then?
Yeah, so they recruited just over 1,700 patients per arm, so a total of nearly 3,500 patients, of which 1,733 were randomized to the 2-yearly surveillance and 1,719 were randomized to the endoscopy at need. There were some patients that dropped, but the vast majority of patients continued in the trial and could be analyzed for the outcomes.
Okay. And I guess they analyzed the outcomes recently in the last couple of years, what I could gather from reading the paper. So can you just briefly summarize the primary outcome and then move on to secondary outcome, just to what the authors have reported?
Yes, they found no difference in overall survival between the two. So essentially, patients died at equal frequency, whether they were surveyed or monitored with a slightly less intensive way.
Okay. And with regards to secondary outcomes, are they anything important that you picked up? I know there are multiple, but maybe you can mention maybe some of the important ones. effects?
Yes, so among the secondary outcomes, they also found no difference in cancer-specific survival. And I shall stress that this is death by any cancer. So obviously, you think about that cancer, esophageal adenocarcinoma will be commoner than other malignancies, but obviously elderly Barrett's patients can develop other malignancies. So there was no difference in cancer-specific survival. And interestingly, although there was a slight predominance of the surveillance in terms of number of esophageal adenocarcinoma diagnosis, this was not statistically significant. So they had 2.3% of patients diagnosed with cancer, esophageal adenocarcinoma in the surveillance, and 1.8% in the endoscopy at need. But in terms of another secondary outcome, which was cancer stage, and perhaps this is what my interest most in terms of trying to understand and explain, the results of the main outcomes, what I found very striking is that among the cancer patients, or the patients diagnosed with cancer in surveillance, more than 50% of these cancers were stage higher than T1A. So if you remember from the previous podcast, we discussed that T1A is really the cancer that you want to diagnose on surveillance in order to initiate endoscopic treatment with curative intent. And we would expect the majority of these cancers to be on a 2-yearly surveillance at this stage so that an intervention can be started. Surprisingly and rather disappointingly, 75+% of patients with cancer were not at stage 1A, so were higher than that stage. And in particular, nearly 50% were stage 2 or higher, suggesting that perhaps the quality of the endoscopy or the ability of the endoscopist to detect early cancer or even pre-cancer stage was in fact not as high as one would expect in an ideal case scenario.
So based on what you said, you know how we were performing endoscopies in 2010, 2015. What do you think could have been the contributing factors in terms of endoscopy quality at that time? So let's say to go back 10 years ago. And how has that technology or things changed in this day and age, where the practice is a bit different in when we perform surveillance for Barrett's?
Yeah, I mean, I think, arguing from the results, I would interpret this that the main contributing factor at not achieving full prevention of deadly esophageal cancer in this trial was the fact that this is really reflecting district general hospital practice. So yes, there might have been some expert centers with endoscopies with particular interest in Barrett's esophagus in the trial, but the vast majority of patients were seen in a district general hospital as part of general endoscopy service. And one would argue that perhaps if the endoscopists are not particularly dedicated or even interested in this particular disease, perhaps the quality of their endoscopy might not have been as good as we would have hoped. And therefore, the diagnosis of precancerous and early malignant disease not as effective as it should have been.
Massa, this is sort of game-changing paper. Depends on how you interpret, I guess. But for a person, let's say, who doesn't have a special interest in this, and I just take the bottom line, surveillance doesn't work. Why are we doing that? Can you just give a couple of comments on how you interpreted the results of this study, what impact it would have on your own clinical practice?
So, obviously, we've already started to receive inquiries as part of our specialist societies in the United Kingdom about physician querying, is Barrett surveillance, does it make sense should we actually stop doing surveillance if the outcome of this trial is as such? And from a public health perspective, perhaps one would say, yes, maybe, it's not justified to continue surveillance based on sort of the facade of this result. But I think we really have to dig a little bit more into the inclusion criteria and on the results of this trial to understand what the answer is to this question. So I have to say that, first of all, 25% of patients recruited into this trial did not have intestinal metaplasia. And we discussed in the previous podcast that intestinal metaplasia is one of the risk factors for cancer in Barrett's esophagus. So they had a population of patients that perhaps was not the true Barrett's esophagus population that we are interested in terms of surveillance. The other thing that needs to be pointed out is that the control in this trial is not a no surveillance. So we are not comparing a population of patients that are surveyed to a population of patients that are not surveyed. 60% of the patients recruited into the endoscopy need arm did have endoscopies. And the frequency, the interval among endoscopies, the median interval was 2.5 years. So we are comparing a pure endoscopy surveillance population with something which is in between no surveillance and surveillance, with the frequency of procedures, which was even actually lower than what we would recommend in general practice, which is 3 years. So this is important to understand the results of this trial. And obviously, the other thing that it's really striking is that when you then looked at the mortality by esophageal adenocarcinoma in patients surveyed in the surveillance arm, the disease-specific mortality in patients diagnosed with cancer on surveillance was 55%. So more than half of the patients diagnosed with cancer on surveillance actually died of esophageal cancer, which is really striking and points to the fact that the quality of the endoscopy must not have been good. And if we draw the parallel with what we do in lower GI cancer, so if you have a FIT positive test, you have a colonoscopy by an accredited endoscopist who is very skillful at diagnose and treat adenomas. So perhaps we should think about that from a public health perspective. Rather than stopping surveillance altogether, we should think about how to maximize the outcome of surveillance, having endoscopists who are dedicated and skilled at recognizing and preventing the final outcome, which is mortality by esophageal cancer.
And is there any evidence already to suggest the quality of your endoscopy changes whether surveillance is beneficial or not? At least is there any preliminary evidence already exist?
Yes, so we actually published in the UEG journal early on this year the outcome of our specialist Barrett surveillance. And this is a longitudinal study which has been going on for more than 20 years. So if you go back at the design of this trial, in fact, actually this speaks about the same quality of technology because a lot of these patients were surveyed early 2000 years. And what we found very interestingly is that the incidence of cancer in our population was 3 times as much as in the BOSS trial. So in the BOSS trial, they found a yearly incidence of cancer of 0.23% per year, whereas we found 0.7% per year. And when we looked at the cancer stage in our cohort, that was strikingly different. So the vast majority of cancers were T1A. And when we then looked at the cancer-specific mortality, only 6.3% of people diagnosed with cancer on surveillance in our cohort died of esophageal cancer. So obviously, this is a super specialistic service, but does speak of the fact that if you improve the quality of surveillance, so if you really concentrate on getting these patients seen in a specialist service, you really can maximize the outcome and achieve the overall goal, which is protecting from esophageal cancer-related death.
So would that be your sort of bottom line for, let's say, me as a general gastroenterologist practicing in a hospital, that you wouldn't change practice at this stage? You would continue surveillance, but take measures or put practices in place so that people who doesn't have to be a specialist in this, but just should have some kind of, let's say, interest in doing this, some kind of experience in recognizing dysplasia, some kind of experience in optical diagnosis of any knobbly bits within the Barrett's. Is that the bottom line?
I think the bottom line is along these lines, Pradeep, and I think this is the direction where we should move. Of course, in terms of how physicians and hospital services work, is a unique guideline recommendation. So, in fact, actually, in the UK, we are working at the moment on a revised BSG, British Society of Gastroenterology guidance for Barrett's esophagus, and will be certainly taking into account the results of the BOS. But I was very interested to hear recently that there's been a change in the Dutch guidelines that has been announced and implemented as of last month, where the Dutch hospitals will be stopping surveillance in people with Barrett's esophagus less than 5 centimeters, recognizing that short segment of Barrett's have low cancer risk. And in fact, the BOS trial did show that actually the event cancer is not a very common event, and that patients with longer segment of Barrett's have higher risk. So the Dutch have stopped, as of last month, surveillance in patients with Barrett's less than 5 centimeters. Whether this is the right choice or not, it's difficult to say. I mean, it's certainly driven by health economic perspectives. But I think from a hospital point of view, yes, I think if you want to get the most out of your surveillance, perhaps identifying the gastroenterologists with a particular interest in this disease who will be committed to take lots of Seattle protocol biopsies in long segment Barrett's, or will spend a little longer and with more expert eye identifying signs of dysplasia.
Massa, that was a very excellent summary, and coming it from you really is important because you're involved in writing these guidelines and revising the BSG. Can I ask when we expect to see the new BSG guidelines?
Yeah, we aim to complete the work by September this year, and disseminate hopefully shortly after.
Okay, so for our listeners, the BSG is the British Society Guidelines on Barrett's. Before we draw close, Massi, any final comments or any advice, piece of advice?
Yes, I think we have to be committed. If we decide that we are going to keep seeing these patients, we have to do them a favor and do our job properly. And as we do for IBD, dysplasia, surveillance, or monitoring or other conditions, we really have to take the full job on board. But also the other thing, perhaps, there are some recommendations from guidelines whereby age is an important element. And we know that, as we discussed, these patients are highly comorbid, and therefore, considering discharging them from surveillance when probably the expected benefit from surveillance is not that significant, and focusing on the patients that really, have a longer life expectancy and they have more, years to develop the final outcome that we want to prevent.
Thank you, Massi, for your extra time for this extra episode.
It was great to discuss with you, Pradeep, and thanks for asking me to be part of the UEG podcast again.
Thanks.